Namaskar. We would like to welcome you all on behalf of Independent Research Ethics Society, AYUSH Samriddhi International Webinar Series. And this particular series, specific series, is really inspired by Professor Kamini Dhimanji. We are grateful to Professor Kamini Dhiman, Professor and HOD, All India Institute of Ayurveda, New Delhi. Really grateful, madam. Thanks. Welcome. And today's speaker on the topic, Dr. K.P. Vidya, Assistant Professor, Department of PTSR, Government Ayurvedic College, Kannur, Kerala. So welcome both of you and all the expert of the dais. I would like to welcome. Thank you. Thank you very much for joining us. Due to your inspiration and overwhelming support, we are enabled to continue this journey up to infinite. So, before, if am I audible to you, Nishanji? No. So, I would like to invite Kamini Dhimanji. Welcome, madam. Kamini Dhimanji, welcome.
Namaskar.
Namaskar.
In the series of Sri Rog and Prasuti Tantra, today we are here to discuss regarding anti-Mullerian hormone, that is AMH. I would like to, at the outset, welcome all the participants join over here, all the experts, Nishanji, and the speaker of the day, Dr. Vidya. She is from Kerala, assistant professor at Kunnur, and she has done her post-graduation in the subject of PTSR. And as far as the topic is concerned, anti-Mullerian hormone is nowadays we can say that each and every patient knows about that. When patients are coming to OPD, they discuss about AMH. My AMH is low, my AMH is high, my AMH is this and this. So what is that? What is the importance of that AMH in gynecology? And when AMH is low or high, they don't have any we can say that they don't treat regarding that AMH to correction of that, but some alternative is always advised to that patient that your AMH is low, you have to go for IVF, you have to opt this and this treatment protocol. So how AMH is important in the life of a female, and what does it do, and why we have to focus, and why we have to understand, and what is the answer that we can provide to the patient is very much important. As that is, as far as the physiology is concerned, AMH is related to function of the ovary, that is the selection of the follicle, dominant follicle, or to maintain the ovarian reserve or maintain the physiology of the ovary, all are related to that, this hormone. But when it is reduced or increased, we have to think according to our principles, and according to our principles, we have to treat that patient. Sometimes it is due to Kshayaj Avastha, sometimes it is due to Avaranajanya Avastha. So, according to patient, according to critical analysis of the condition of the patient and Dashvid Ashtavid Pariksha, only we can know that which state is causing this disturbance of the level of AMH. That is very much important. And as far as the release of this hormone, when follicle is growing, that follicle will release the AMH. But after some level, we can say that after the 8 mm, or the follicle will not release the AMH. So when we advise the AMH, we can advise throughout the month. At any day, we can advise the patient to go for AMH. बाकी हॉर्मोन्स जो हम बताते हैं, दूसरे हॉर्मोन्स, उसके लिए वी हैव टू डिसाइड पर्टिकुलर डे फॉर the assessment of the level of that hormone. But in the case of AMH, it is not like that. So बाकी की बातें डॉक्टर विद्या will explain, and After her presentation, we will have question answer and we will discuss. So over to you, Dr. Vidya. First of all, you introduce yourself. I introduced from my point, but you can tell about some more about yourself, and then you can start your topic. Over to you, Dr. Vidya.
Thank you, ma'am. Thank you for introducing me and thank you for giving me an opportunity to present the important topic in gynecology in this platform. As you have already introduced me, I am Dr. Vidya KP from Kerala, basically from Kozhikode or Calicut. You can, I think you may know that. Now I am working as assistant professor at Kannur Government Ayurveda College. Previously, I have worked as assistant professor in Saharanpur, local Ayurveda college for 1.5 years. Now I have joined here and I am having, I think, 2.5 years of experience in teaching and almost 8 years experience in medical field.
Nice, nice, nice. Welcome.
Thank you, ma'am. So shall I start, sir and ma'am?
Yeah, yeah, yes, yes, yes. You can start.
So uh, shall I share my screen or will
Yeah,
you?
you can
Yeah.
share.
Ah,
If any problems are, will share. You share yours.
oh, okay, ma'am. Can you see the screen, ma'am?
No, not visible.
So could you please share the screen, ma'am? Then,
Yes, I'll tell sir to share. पवन सर
oh,
आप स्क्रीन शेयर करेंगे? पवन सर. He is sharing.
okay.
Yeah. Yes,
Sir,
yes.
you can directly go to the second slide, sir.
Yeah.
So shall I start, ma'am?
Yeah, sure, sure.
Okay. So good evening, all. So we all know that to become parents is the dream of almost all couples. As we all know, infertility is affecting a significant portion of the population globally. As far as the recent studies are concerned, about 17.5 percentage of the worldwide population seeks infertility treatment in 1 year. And there are so many methods to assess the female infertility factors, and ovarian reserve is one among them. While we explore the ovarian reserve, anti-Mullerian hormone is the latest lab test to assess the ovarian reserve. The antral follicle count is now replaced by AMH due to its specificity and accuracy. Hence, today we are discussing about the importance of AMH in gynecology. So, these are my contents. So, moving on to the next slide, that is introduction. Sir Alfred Jost has discovered AMH. It is said that while performing a surgery, he discovered a second male factor which is responsible for the sex differentiation in a fetus, and that is AMH or Mullerian inhibiting factor. So it is a glycoprotein, it is a dimeric glycoprotein, and is a peptide growth factor which is present in both males and females. It is also known as MIF, that is Mullerian inhibiting factor, and also anti feminine hormone. So, moving on to the next slide, the relevance of this topic. As I've already told you, AMH is a marker for ovarian reserve and also is a marker for menopause onset. It is one among the diagnostic tool for the PCOS, and by its value, we can assess the probability of conception, and also it is used to assess the gonadal toxicity after the cancer therapies. Moving on to the production of AMH. Next slide, sir. As I've already told you, it is present in both males and females. In males, it is produced from the Sertoli cells, and in females, it is produced from the ovarian granulosa cells or follicles. So moving on to the ovarian reserve. What is ovarian reserve? Ovarian reserve is the capacity of ovary to produce or provide the egg cells that are capable of fertilization. Thus, a good ovarian reserve can lead to successful pregnancy. As we all know, women are born with lifetime supply of eggs, and it also indicates the quantity of eggs that are available in the body.
What happened? It is not audible from my side.
Not for me also. It's not audible.
Can you hear me, ma'am? Hello, ma'am.
Hello, yes.
Can you hear me, ma'am, now? I
Yes,
think
now,
some
now, now.
some problems with the net connection, right?
Yes, now it's audible. It was not audible previously. Yes, it's
Okay.
fine now.
So from where I have to repeat, ma'am? I am not sure about that.
Uh, I heard about just that in a male it is released from Sertoli cells. After that, I was not able to
Ha ha
listen.
ha.
Yes.
Okay, okay, ma'am. So from ovarian reserve, from there I'll be speaking, मैम. I think अभी बहुत बारिश हो रहा है मैम, इसलिए थोड़ा network issues होगा, I think so. We'll try,
Okay.
ma'am. Okay,
Yeah.
ma'am. So moving on to the ovarian reserve. So ovarian reserve is nothing but the capacity of ovary to provide the egg cells that is capable of doing fertilization. So thus a good ovarian reserve can lead to a successful pregnancy. And we all know that women are born with lifetime supply of eggs. And AMH is produced from these egg sacs or follicles, and it indicates the quantity of eggs. Once again, repeat, it indicates the quantity of eggs, not the quality of eggs. And it also indicates the number of fertile years. Now we'll see the action of AMH in ovary in the next slide. Ah, this is the details of sex differentiation. So I have already told you that it is produced from the Sertoli cells in males, and it is produced from the ovarian follicles in females. So how the sexual differentiation happens? So, in the presence of SRY gene, the XY chromosome, there is SRY gene, and with the presence of SRY gene, naturally the gonads will become the male gonads, that is testicles, and from the cells in turn produces this testosterone, which helps in the development of Wolffian duct. Thus, the born child will be a male phenotype child. And in case of females, what happens? There is no AMH secretion because naturally SRY gene is not there, and the gonads will directly becomes the ovaries in females. And as there is no AMH production, the Mullerian duct is not developed. Mullerian duct is developed, and Wolffian duct is not developed. Thus, the baby formed will be a female phenotype. Next slide, sir. Now we'll move on to the action of AMH in the ovary. So it helps in the follicular preservation. It prevents the unnecessary and excessive recruitment of primordial follicles, and it restricts the follicular sensitivity toward to FSH, and indirectly helps in the monofollicular growth. We know that among the primordial follicles, some of them grows into the antral follicles, and among them one becomes the Graafian follicle and is ready for the ovulation. So what happens to other follicles? They gets preserved for the next cycle, and this preservation is done by the AMH, and because it restricts the follicular sensitivity towards the FSH. So the next slide, the picture is shown. So in this picture, I don't know whether it is clear for you people. So in this picture, you can see that the pre-antral follicle and the small antral follicles are producing AMH. Once it grows into the size of 5 mm, FSH will come into the play. And what happens? FSH will select or recruit the follicles which are needed for the ovulation. Till then, AMH is produced. Once the FSH is produced, AMH will stop its activity. So what happens? Only one follicle will be grown as Graafian follicle and will be matured for ovulation. Okay, so the rest of the follicles will be preserved for the next cycle. This action is done by AMH. So what happens if AMH is not there? All the follicles will be stimulated by the FSH. So it can lead to the polyfollicular growth. So that is not happening everywhere. So this AMH is protecting our follicles from being sensitized by the FSH. Now we shall see the factors influencing AMH. Next slide, sir. So AMH is decreased by increasing age. It is inversely proportional, and it is also decreased if oophorectomy is done. As you all know that ovarian follicles are producing AMH, and once oophorectomy is done, there is no production of AMH. That is why it is decreased in oophorectomy cases, and also decreased by the administration of gonadotropin, agonist, chemotherapy, and radiation. And it is increased in PCOS condition, and it is unaffected in the menstrual cycles and also by the OCPs. There is no fluctuation in AMH hormone during the different phases of menstrual cycles and also by the OCPs. That is why it is more important. It is a marker of obesity by anything. Now we'll discuss about the causes of low AMH. By increasing age, AMH is reduced because the number of recruited follicle will be reducing by the increasing age. And the other factors that is causing the low AMH are hormonal imbalances. We'll discuss in detail in the coming slides. Idiopathic factors, environmental factors, and genetic factors. So as I've already told you, by increasing age, AMH will be reducing because the follicles count will be reducing, because every month we are using one follicle each from the ovaries. Okay. So next slide. The autoimmune diseases such as anti-ovarian antibodies and the other hormones like thyroid dysfunctions, diabetes mellitus, hyperprolactinemia, everything can diminish the AMH. And some of the genetic factors affecting AMH are: the gene for AMH is considered as chromosome 19, and in chromosome 12 we have AMHR2 receptor. So any mutation to this receptor can affect the follicular recruitment and development, which leads to infertility. Now we shall discuss about the environmental factors. So the air pollution, smoking, alcohol, coffee use. Only one-time coffee use does not affect the AMH, but long-term coffee use can affect the AMH. And the uses of pesticide can also result in diminishing ovarian reserve. Okay. Some of the pathological conditions that affect AMH are the endometriosis, PCO, any disease that can affect the anatomy of ovary can result in diminished AMH. So they are endometriosis, PCOD, SLE, ovarian tumors, and Crohn's disease. Next slide, sir. Now we'll discuss about the relation between AMH and PCOS. As you all know, PCOS is a heterogeneous multi-system endocrinopathy, and there is accumulation of pre-antral and small antral follicles. There is no ovulation happening. An ovulatory condition is PCOS. So what happens? The follicles, pre-antral and small antral follicles, will produce more and more AMH. And it is said that secretion of AMH from a polycystic ovary is 75 times higher than a normal ovary. And insulin will promote activation of primordial follicles, and there are more and more primordial follicles happening in PCOS, and that is why there is more and more production of AMH in PCOS. Now we shall see why AMH is suggested, why it is more superior than other markers. Because I have already told you, it is stable throughout the cycle. It is of higher sensitivity and specificity, and hence it is superior than the other markers. Next slide, sir. We have already discussed about the advantages. There is advantages to AMS too. That is, measurement of the AMH is not yet standardized, and there is poor correlation of AMH with the oocyte quality. I've already told you it indicates the quantity, but it cannot give a value of the quality of the ovum. So this is the recent chart for the normal AMH values. The normal values are considered as 4 to 6.8, and as the value decreases, it indicates the diminished ovarian reserve, and if the value increases, it indicates the PCOS condition. Again, summarizing the uses of AMH, it is used in infertility treatment to assess the ovarian reserve, and it helps in the forecasting of reproductive lifespan. It indicates the ovarian dysfunction. It is also used in gonadotropic cancer treatment to assess how much damage has occurred after the cancer treatment to the ovaries. It helps to individualize the dosing of ovarian stimulation therapy, thereby improving the efficiency and safety to IVF. Now, moving on to the Ayurvedic point. In Ayurveda, sex differentiation happen in the second month of pregnancy. So अत एव द्वितीये घन संजायते अत एव शुक्रस्य बाहुल्यात् जायते पुमान. So for the production of puman, the shukra is important. So here shukra can be considered as both the SRY gene and also the AMH, which helps in the sex differentiation. And moreover, Shukra is present in both males and females. So I think it can be included under the Shukra Dhatu. And Acharya Charaka explains that the Srikara Bhavas, while describing Bija Bhaga Dushti, where he tells that the Srikara Bhavas, if not developed properly, it can lead to several forms of Vandhyatva. It can also be included under the Artava Dhatu, as Artava Nasha can lead to Bandhitva, and diminished AMH can lead to Bandhitva. Means indicates it is not a causative factor, it is an indicator. We can also think about the concept of Antapushpa told by Acharya Kashyapa, because Antapushpa clearly indicates the ovarian follicles, and AMH is a marker for that ovarian reserve. So diminished AMH indicates diminished ovarian reserve, that is Dhatu Kshaya Janya Vikara. So next slide, sir. So Dhatu Kshaya Janya Vikara can be either due to Vata Prakopa or Dhatu Kshaya, vice versa. The Dhatu Kshaya leads to Vata Prakopa, and Vata Prakopa leads to Dhatu Kshaya. Both these conditions can lead to the Artava Kshaya. Now, scope of management in low AMH. As we all know that Vriddhi and Kshaya are the under the influence of Kala. Kalakrita Vyadhis are asadhya, and destruction is an inevitable process. But still, we can use the Rasayana therapy as it can maintain the Yuvatva, and hence the Rasayana therapy is very much beneficial in the low AMH condition. By use of the Jivaniya drugs and also Hitahara Vihara, we can improve the quality of ovarian reserve, and it might be beneficial in treating the infertile couple. So this is the definition of Rasayana therapy. Labhopayo hi shastanam rasadinam rasayanam. The proper formation of artava from rasadhatu is achieved by the Rasayana therapy. And Acharya has told that Kshine Shukrakari Kriya. So, in case of Artava, Kshine Raktakari Kriya is mentioned in our classics. And while adopting the concept of Samana and Vishesha, Vriddhi Samana hi Sarvesham Viparite Viparyaha, the similar treatment is given in modern medicine also by agonist and antagonist treatment. And in our classics, the preconceptional care, Acharya has explained about the um, preconceptional care both for the males and females, in that narim tailena masha ischa pittalaihi samupacharit. So both taila and masha are artava janaka, and pittala drugs can improve the artava. So these are the treatment option. We can give snehapana with either sukumara ghrita, kalyanaka ghrita, Mahakalyanaka Ghrita, Mahanarayana Taila. Every medicines are indicated in Vandhya. And after this Neyapana, Shodhana can be given either in the form of Vamana, Virechana, Nasya, and Basti. And importantly, the Sthanika Chikilsa, the Uttara Basti, can improve the quality of the ovum, which helps in the infertility treatment. Now moving on to the AMH high levels, it can be correlated either by the Nashtartava or Artava Kshaya. As Madam has already told during the introductory session, it can be either due to Dhatu Kshaya or it can be either due to Avarana. So either Shrotorodha or Vata Vaigunya happens. There is accumulation of Kapha and Pitta. So actually Vata Kapha causes the Avarana to the Artavaha Shrotas, which leads to Nashtartava. So in the management, in such cases, the Srota Shodhana is the prime important thing. And after that, Agni Samikarana and Artava Janana drugs can be given. And also the other symptomatic treatments can also be given along with that. Next slide, sir. So PCOD can be either obese PCO or lean PCO. In obese cases, we'll give Medohara drugs and Artavajanaka drugs too. The Avarana reducing drugs can be given. Some of the examples are Methika, Dhatri, Haridra, Sarshapataila, Trifala, Shadharana tablet and Shilajatu tablet, which are Kabha Medohara, and Pitta increase can be achieved through these drugs. So Artavajanagana can properly happen once Pitta is increased. And in case of lean PCO, more Tarpana should be given, and also Srota Shodhana should be given in lean PCO. Tila, Masha, Pipalli, Kumari, Lashuna, Shatapushpa, and Shatavari. You all know the importance of Shatapushpa and Shatavari, which is told as a separate chapter in Kashyapa Samhita. Yana Pashyante Vipalam Chaya. Like that sloka is given in detail in Kashyapa Samhita. Some of the research works in Ayurveda are the effect of Ayurvedic treatment protocol on diminishing ovarian reserve by Dr. Divya U, which was conducted in Trivandrum Ayurveda College. And the treatment protocol given to the DOR patients was, so here they have considered the reduced AMH as Dhatukshaya Janivandhitva, and the protocol was Pachana. Externally, Udvartana was given as Kabhamedohara, and Snehapana was given with Sukumara Grita. Abhyangoshma Sveda was given for the Bahya and Abhyantara Sneha, and which Virechana was done as a Shroto Shodhana procedure, Sukumara Eranda Taila. And then after rest, patient was given Vasti. You can select Rajayapana Vasti also to improve the quality of ovum and also in the recruitment of the follicles. Next slide, sir. Yoga Basti and Uttara Basti was also given. Rasayana, Lashuna Rasayana can be taken. Shatapushpa Kalpa, Shatavari Kalpa, etc. can be taken in diminished ovarian condition. And this is the clinical efficacy. This is another study, clinical efficacy of Ayurvedic treatment regimen on sub-infertility with PCOD. So here Kabha, Medohara and Avarana removing drugs are given. So the Trifalakwata, Chandraprabha Guliga, Mani Bhadragula, etc. were given in stage 1. And in stage 2, Shatapushpa and Shatavari again it is given. So it enhances the importance of Shatavari and Shatapushpa. So Shatavari enhances the follicular maturity and it is Artava Janaka. Shatapushpa helps in the follicular maturity. So moving on to the discussion and conclusion, most often causes for this infertility are autoimmune, and inadequate germ cell migration during the embryogenesis can lead to the reduced recruitment of the follicles in ovary. And in some cases there is accelerated atresia, that is in case of diabetes mellitus, thyroid dysfunction, and by the aging, increased age, there is accelerated atresia in autoimmune diseases too. And after following certain therapies, like if you're doing any surgeries, any pelvic surgeries, the AMH is found to be reduced. Either it can be laparoscopy or laparotomy, anything. Any pelvic surgeries can lead to the diminished ovarian reserve. So some lifestyle diseases like obesity and sedentary lifestyle, everything can lead to fluctuation in AMH. So in case of infertility, proper preconceptional care should be given. After proper Shodhana, Rasayana therapy can be given in diminished ovarian reserve, and proper Ritumati Charya should also be uh, educated to the patients who are coming for the infertility treatment so that we can improve the ovarian reserve. These are my references. Thank you.
Yeah, thank you, Vidya, for a very crisp and to the point presentation. I would like to add on something that the title we have selected, that AMH in gynecology. So other than fertility issues, AMH is being considered in the ovarian neoplasm also, because it is having anti-proliferative effect. AMH is having.
Yes, ma'am.
Sometimes in neoplasm of ovary, it is considered. So this is also nowadays being focused in such cases, that what is the level of AMH. And as far as the PCOS is concerned, we have focus, but sometimes it is being discussed that why it is being raised in the cases of PCOS. What is the pathology behind that, how it is being increased in some cases, that when patient is not able to conceive, AMH is low, but in the cases of PCOS it is being increased. What is the pathology behind the raised AMH in such cases? So in the starting, as I told, that AMH is released when the follicle is the having size small, less than 8 mm. At the time it will release. So in the cases of PCOS, what happens that follicle is not growing, but there are lot many follicles who are trying to grow, and these follicles are releasing AMH, and because of this multiple release of small follicles, the level of AMH is found to be raised in the cases of AMH, PCOS. So it is also of the great concern nowadays in the practice that AMH is being increased in the cases of PCOS. So by the level of AMH also you can know that this patient might be having PCOD or PCOS. And uh, when the patient is having continuously declining AMH level, we can indicate the what can be the probable age of menopause in that female. So nowadays some studies are being going on that every fall when the AMH is being reduced by 0.10 nanogram per ml, and it is increasing the chances of early menopause by 14%. When it is reduced, it will increase the chances of early menopause. So this is also to be taken into consideration when the AMH is continuously being reduced. We can do counseling of the patient that you might approach your menopause earlier. So it can be the predictor of the early menopause in the patients of menopause also. And in we can say that pediatric cases also it is sometimes that is being considered nowadays as a signal of the future consequences. What will be the future consequences in this female girl if she is having deranged AMH, and what will be her future regarding her gynecological health or her menopause health in long term, or fertility issues in that girl when the AMH is disturbed. Nowadays it is being focused, so I'm uh, adding doing add on the points in such cases. And in some congenital, we can say there syndromes like Turner syndrome and Klinefelter syndrome also, the level reflect the what is the degree of testicular dysfunction in such cases. This is also being taken into consideration nowadays in such type of cases. This was some add-on in from my side that was not included in your presentation. So now we will take up the questions of the participants if they have some questions. So anybody if want to ask the question, then can ask. Or some even want to add the experience, they can add. Nah, Sushila, if you want to ask, पूछो अपना question.
नमस्ते मैम
हाँ,
मैम
नमस्ते.
what is the relation between AMH level and Down syndrome? Is it
Yeah.
some specific? As you mentioned that AMH is found अभी अभी आपने uh, अभी आपने मेंशन किया कि इन कंडीशन में AMH भी रहता है तो मैम
हाँ,
डाउन सिंड्रोम में भी कुछ रिलेशन है इसका
हाँ, बिल्कुल बिल्कुल उसमें रिलेशन रहता है ना, क्योंकि फॉलिकल्स डिप्लीशन मिलता है इन केसेस में. द ओवेरियन फॉलिकल्स आर डिप्लीशन. So monitoring of AMH is, we can say that, indicator of premature ovarian insufficiency in such type of cases. तो उसमें आपको मिलेगा ही मिलेगा कि पेशेंट में deranged है AMH वैल्यू in such cases also. वो भी एक जो है उसमें लिया जाता है. बट इन द केसेस ऑफ क्लीनफेल्टर एंड टर्नर सिंड्रोम जो है वो भी उसका आजकल जो है कंसिडरेशन में लिया जाता है. Dysfunction, to assess the dysfunction, what is the we can say the degree of dysfunction or level of dysfunction, उसको जानने के लिए जो है इसको दिया जाता है. डिसफंक्शन तो हमें पता चल गया कि हाँ इसमें डिसफंक्शन है, बट AMH कम है कि ज्यादा है वो इंडिकेट करता है कि किस टाइप का डिसफंक्शन इन टाइप के पेशेंट्स में आपको मिल रहा है. इसीलिए उसको जो है वो जानना जरूरी रहता है ना.
जी मैम थैंक यू मैम
क्योंकि
एंड
रिप्रोडक्टिव
वन मोर
कैपेसिटी,
क्वेश्चन
यस, रिप्रोडक्टिव कैपेसिटी जो है उसके ऊपर भी इसका इफेक्ट आ रहा है. उसको चेंज हो रहा है कि जैसे बच्चों में भी जैसे डिक्लाइनिंग AMH लेवल्स अगर शुरुआत से ही रहता है या
हाँ हाँ
इंक्रीज रहता है तो वो भी इंडिकेट करता है, बड़ा हुआ भी इंडिकेट करता है कि रिप्रोडक्टिव कैपेसिटी जो उसकी डिक्लाइन की तरफ जा रही है. बेशक बड़ा हुआ है तो भी, और
बिल्कुल
घटा है तो बताता ही है, लेकिन बड़ा है तो वो भी इंडिकेट करता है.
तो मैम जैसे अभी आपने एक्सप्लेन किया कि AMH का हाई लेवल क्यों होता है पीसीओडी में? बिकॉज जो छोटे छोटे फॉलिकल होते हैं वो
यस,
इंडिविजुअली।
वो रिलीज करते रहते हैं, इसीलिए उसका
हाँ जी,
लेवल बढ़ता
हाँ
है।
जी, हाँ जी,
हाँ। हम्म।
हाँ जी।
और
मैम
जैसे
हमारा
उसका
एट द टाइम ऑफ
साइज बढ़ गया साइज, तो वो रिलीज करना बंद कर देता है ऐसा।
पर सेकेंड जी
हाँ।
मैम। तो एट द टाइम ऑफ ट्रीटमेंट हमें प्रॉपर ओव्यूलेशन के मतलब ओवरी से ओव्यूलेशन पे फोकस करना चाहिए,
यस
या हमें
यस।
एएमएच के लेवल को देख के मतलब कैसे हम हाउ वी शुड अप्रोच टुवर्ड द ट्रीटमेंट ऑफ
या
सेरेब्रम कि
उसमें
हमें एएमएच।
एएमएच, हाँ हाँ, एएमएच के लेवल को देख के, जैसे कि मैंने स्टार्टिंग में बोला कि एएमएच इंडिकेट्स की क्षय संप्राप्ति है कि आवरण जन्य संप्राप्ति है। ठीक है। अगर
जी
आपको
मैम।
उसमें लेवल कम है तो समझ जाओ कि क्षय संप्राप्ति है। फॉलिकल रिलीज तो कर रहा है एएमएच, बट उतने ज्यादा छोटे फॉलिकल्स भी इतने ज्यादा नहीं है कि इसका
जी मैम।
एएमएच जो है वो नॉर्मल ऑप्टिमम लेवल तक आ जाए। तो छोटे फॉलिकल्स की भी कमी है, ये बताता है। तो मतलब वो क्षय की संप्राप्ति बताता है। और जब बड़ा हुआ लेवल है तो कि छोटे छोटे फॉलिकल है, बट संख्या उसकी ज्यादा है, तो मतलब कहीं ना कहीं आवरण है जो उसकी न्यूट्रिशन को हैम्पर कर रहा है। उस आवरण को आपने हटा दिया तो जो वहाँ फॉलिकल एट प्रेजेंट अवेलेबल है, उसको आप नरिश करेंगे, डेवलप हो जाएंगे, ग्रो कर जाएंगे, ओवुलेशन हो जाएगा, है ना।
जी मैम।
हम्म।
मतलब एक बार ही हम जो जैसे शयात्मक संप्राप्ति है तो उसमें वृंगण के हिसाब से जाएं, और फिर दूसरा जो एएमएच रेज्ड हमें मिले, पहले रेज्ड
हाँ
नहीं था या अभी रेज्ड मिल रहा है, तो हम उसमें लेखन के हिसाब से आवरण के हिसाब से चिकित्सा करें।
हाँ हाँ।
यही मतलब
लेखन
हुआ ना
करना
मैम?
है, स्रोतोरोध दूर करना है,
हाँ,
आवरण को
करना है। हाँ जी।
करना है। हाँ हाँ हाँ।
थैंक यू मैम, थैंक यू फॉर एक्सप्लेनिंग। थैंक यू।
सुधा, डॉक्टर सुधा। डॉक्टर सुधा नहीं सुन रही हैं। दीपिका, इफ यू हैव एनी क्वेश्चन कैन आस्क।
Yes, ma'am. I have a case of PCOD. Can I discuss that, ma'am?
Yeah, yes, you can discuss. Lot many
Yes,
experts are
ma'am.
there, they can share their view. Dr.
Yes.
Vidya is also there. She
Okay,
can.
ma'am.
Mhm.
She's 23 years, married life of 2 years. When she came to me in 2019, and her AMH was 21, and she had the problem of amenorrhea since the time of her menarche, and she was on continuous OCP pills under the modern gynecologist for continuous 3 to 4 years. And when she came to me, what I did was I gave her Virachan, ma'am, in 2019. That time she
Okay.
had symptoms of scanty menses,
Mm-hmm.
and only on OCP she used to menstruate, and
Mm-hmm.
it was scanty menses. So that time I was not much into woman. I didn't have confidence, so I just gave the Shodhan line of treatment of Virachan, where I felt now I did a mistake, because if I should have increased the pitta, I feel, and I diminished it. I don't know. This is what I feel. I did a mistake there. And after that, there was no improvement at all. I tried with various medicines like Chandraprabha, Raja Pravartini, Kumari Asav, Shatapushpa Churna. Even I gave Shatapushpa Taila Nasya also, but there was no effect at all. Maybe in a period of 1 year, she got only once she got normal menses. Otherwise, she got but there was one good effect, that she started getting her menses timely, but it was only spotting. Hardly, not even half a pad a day. For 4 5 days, she used to just get some spotting, or sometimes just visible menses, just strands of blood for 2 3 days, and that's all. I tried with various medication. I was not able to improve her this. Then finally, for 2 years, she was with me because she was so much of fed up of eating this modern medicines. Because she got started getting in proper time, she tried. Then even I tried with Kalyanaka Kashaya, Sukumar Kashaya, and then Brahmi Churan with Kalyana Grit also. So, but I didn't get any good result. Finally, she went to, from Agra, she got her not IVF done. They gave her LH injection during that time and metformin tablets. And within a month, she got very good normal menses. And second month, she conceived, she got aborted. And immediately, next cycle itself, again, they gave her through hormonal injections, LH injection. She conceived, ma'am, and she delivered a baby, normal baby. She had some issues, bleeding issues and all, and she delivered. But now the baby is around 2.5 3 years, but she had not got a menses, and again the same problem. After some 7 8 months, again she came back to me कि I want this time normal conception with Ayurvedic treatment only. Her belief is she got immediate pregnant because she had taken so much of Ayurvedic treatment. I even gave her woman before delivery. She believes it's not because of that. Because of all the pre-treatment what I got, she has a strong belief in Ayurveda. Now again she's come to me, ma'am. I've given her woman and her samsarjan karma is going to get over tomorrow. So now I've stopped seeing her AMH because it's always 21 19 that way. Twice or thrice I've seen. So from the last 1 year, I've not seen her AMH also. But periods are like 2 months, 2.5 months spotting only. And her weight is 59 kgs. Her height might be around 5.2. And she is only having spotting, ma'am, now. Today, again, after this time, after woman on the 25th day, she got a period yesterday. Again, it is just spotting during a samsarjan period. How to go forward with this particular case? I sometimes feel I'm just one step back somewhere. I'm not able to. If I see Kafaj Avaran type, I tried with all Kafaj line treatment also. And sometimes I feel maybe it is Kshayaja also because endometrial thickness is also not going above 4 mm. I've seen at different stages, 15th day, end of the cycle. It has never gone above 4 mm or 5 mm. So I am really confused whether it is Datukshayajanya or Avaranajanya. She has hirsutism, ma'am, and 4 5 kgs of weight gain only she has. Abhi, she was 64. After woman, she has lost around 4 kgs. She's come up to 58, 59 now.
Okay. Anybody want to add in this? Dr. Vidya, will you tell anything in such case?
Ma'am, I think we have to do both Vaman and after that Rasayana therapy has to be given. After Shodhana, we should not leave that patient. Rasayana
No, no.
therapy should also be.
Rasayana with the Satapushpa, yes, Shatavari.
Shatapush very good in such cases because there is Avarana, no? So Pitta, Shatavari is Vata Pitta Shamaka. Hello?
Okay, ma'am.
Yes,
Okay,
yes. Yes,
you're,
audible.
So,
you're audible, ma'am.
so okay, Shatavari is Vata Pitta Shamaka. So in such cases, there is obesity and there is reduced AMH means there is definitely an Avarana cause. So we have to clear that Kapha Avarana. So Ushna drugs should be given in such cases.
No, AMH is not reduced, ma'am. It's increased 21 19.
So, so definitely you have to give Ushna therapy. Ushna and Ruksha therapy should be given. Kapha reduction should be done in such cases.
Okay, now in the when
I think Shatavari is not a good choice. Shatapushpa will be definitely a good choice in such condition.
Okay, ma'am, and along with Satapushpa, anything else?
Kabha Medohara, Prameha Chikilsa can be given. Kabha Medohara, Ruksha, Shilajatu can be given. Shilajatu and the Murchita Tilataila. Tilataila and all is very good Arthavajana. No? So,
Okay,
Snehapana
Tilataila in form of Samana Sneha.
as Shamana Sneha and also as a Shodhana before Snehapana can be given with Murchita Tilataila.
Okay. So now that I've done Vamana with Kalyanaka Grita, ma'am, for her.
So
And
Kalyanaka Grita is a Tarpaka, na? Kalyanagirita is causing tarpana. It is a santarpana type of drugs. So that I think you should
Okay.
select Medohara and apatarpana type of drugs in such cases.
Tela Snehapana.
Yeah, like that.
Okay, ma'am. Okay, ma'am. Thank you.
Thank you.
Thank you, ma'am.
Yes, Divya, in this case, previously that also helped in her previous pregnancy. You did her Bija Shuddhi, that was Bija Sanskar done by you. And after that, her follicle was able to respond to the artificial hormone, whichever she received. But after that, only Sanchodhan, only she got improvement in her issue. So Sanchodhan always help in such type of cases. Whether it is Avran, after Avran, Avran Janya Samprapti, at long term, it result into Kshaya. Yeah.
Yes, ma'am.
Yeah.
Yeah, due to lack of nutrition.
Yes.
Yes, ma'am.
Yes.
Yes, ma'am.
Yeah. Initially, it creates Avran, and that Avran results into Kshaya.
Yes, ma'am. Yes, ma'am.
Yes. So after Sanshodhana, as Vidya told, that after Sanshodhana, you have to give her this Rasayan Chikitsa, and then
Yes, ma'am.
only you will get result in such type of cases. And as far as the OC pills or hormonal pills are concerned, they are not having influence upon the level of AMH. The patient is giving history of that she has taken this contraceptive pills or OCP pills. They don't interfere in the level of AMH. Yeah.
Yes, ma'am. Yes, ma'am.
Yeah.
Thank you, ma'am.
Yeah. Anybody want to add on or ask? Today we are having Dr. Krupa Patel also. She will add on in such, I think, topic. Dr. Krupa?
Good evening, madam.
Yeah, good evening.
It was such a nice presentation. बहुत अच्छा AMH के बारे में बहुत अच्छा जानने को मिला। हम जैसे अभी लास्ट मैडम हमारा जो टॉपिक था कल वो हेतल मैडम का जो किया था, तभी आपने
हाँ,
जो शुरुआत में बोला हम भी यही करते हैं, पर्टिकुलरली मैं तो यही करती हूँ कि हम हमारे पास जो भी इनफर्टिलिटी के पेशेंट्स आते हैं वो पूरी फाइल्स लेके आते हैं, बंच लेके आते
हाँ,
हैं पूरा, तो हम
हाँ,
सिर्फ
हाँ,
उनको देखते हैं कि हाँ चलो, और उनको ये मॉडर्न वाले बता देते हैं कि आपका AMH लेवल ये है, इसकी वजह से आपको कंसीव नहीं हो रहा है। तो मैं पर्टिकुलरली AMH लेवल को एज अ चॉइस ऑफ ट्रीटमेंट देखती हूँ और एज अ प्रोग्नोसिस कि हाँ मुझे कौन सी ड्रग यूज करनी है और मेरी ड्रग मुझे कितना टाइम लेना चाहिए, कितना टाइम लेगा ये ट्रीटमेंट, ये देखने के लिए मैं AMH देखती हूँ। और मेरे पास अब भी 2 पेशेंट ऐसे आए हैं जो मेरा मतलब कॉन्फिडेंस बहुत बूस्ट अप किया है कि उनका एक पेशेंट है उसका AMH था 0.4, तो उसको सभी डॉक्टर्स ने बोल दिया था कि यू हैव टू गो फॉर अ टेस्ट ट्यूब बेबी, कोई आपके पास ऑप्शन ही नहीं है। उनका एक एबॉर्शन का हिस्ट्री भी था, तो उनको बोल दिया था कि टेस्ट ट्यूब बेबी ही करवाना है। तो वो फिर जब मेरे पास आए तो वो उनका कोई PCOD कुछ भी नहीं था, ओव्यूलेशन स्टडी भी नॉर्मल है, सब है, कोई प्रॉब्लम नहीं था, पर वो कंसीव नहीं हो रहे थे। तो जैसे आपने बोला कि एक क्षय जन्य संप्राप्ति है, लेकिन फिर भी शुरुआत हमें शोधन से ही करना है। तो हमने विरेचन, बस्ती, योग बस्ती, रूटीन योग बस्ती, कोई ऐसा स्पेसिफिक ड्रग नहीं, सिंपली योग बस्ती, महानारायण तेल और दशमोत्पाद से। और नेक्स्ट साइकिल में योग बस्ती के साथ में हमने महानारायण तेल की 3 दिन उत्तर बस्ती दी, 5 दिन अनुवासन आस्थापन और इन बिटवीन 3 डेज उत्तर बस्ती। और इन नेक्स्ट मंथ शी गॉट कंसीव, उसको 2 फॉलिकल्स ग्रो हुए थे। वो 3 महीने ये प्रोसीजर के बाद हमने ओव्यूलेशन स्टडी करवाई, तो एक साथ दोनों ओवरी में से एक एक ओव्यूलेशन ओवम ग्रोथ हो रहा था। मुझे लगा था ये शायद ट्विंस में हो सकता है, लेकिन नहीं हुआ। पर फिर भी वो सिर्फ ये 3 महीने हमने शोधन करवाया, शमन भी अभी मैंने बोला ही था, पर उन्होंने ट्रायल लिया क्योंकि ओव्यूलेशन स्टडी अच्छी जा रही थी, और उसी महीने में वो कंसीव हो गई और अभी उसका 4th मंथ रनिंग है। और कोई प्रॉब्लम नहीं है, एंटी स्कैन भी हो गया उसका, तो कोई उसमें प्रॉब्लम नहीं है 0.4 AMH पर। तो वो पेशेंट भी यकीन नहीं कर रहे थे कि 0.4 पे हमको बोल दिया था कि टेस्ट ट्यूब बेबी ही होगा, इतना लो AMH है। तो फिर भी सिर्फ इतनी सिंपली हमने ये करवाई, कोई स्पेसिफिक मेडिसिन ऐसी नहीं यूज की, और ये हो गया। तो ये बहुत ही है कि हमें AMH लेवल को ध्यान में रखना तो है, लेकिन सिर्फ उसको ही पकड़ के नहीं चलना है। हमें जो
हाँ।
सिम्टम, हाँ, जो सिम्टम्स मिल रहे हैं कि ओव्यूलेशन हो रहा है नहीं हो रहा है, ट्यूब ब्लॉक है कि नहीं, वो भी उसके साथ साथ कंसीडर करना है। और मैं ये कभी आफ्टर ट्रीटमेंट AMH नहीं करवाया, आज तक नहीं करवाया। बिफोर ट्रीटमेंट देखते हैं कि हाँ चलो ये बढ़ा है या बहुत ज्यादा कम है। जैसे अभी मैडम ने बोला कि वो 19 या 20 है, तो ऐसा अगर है तो उसमें हम लेखन बस्ती ऐड करते हैं। और ऐसा पेशेंट तो अभी आया नहीं है, 7 या 8 या मैक्सिमम 10 तक का ही मेरे पास आया है AMH लेवल, ये इतना ज्यादा नहीं है, लेकिन उसमें हम लेखन बस्ती ऐड करते हैं। इन जनरल PCOD के पेशेंट में हम लेखन बस्ती करवाते हैं गोमूत्र वाली। तो ये एक अच्छा रिजल्ट मिला कि लो AMH में भी सिंपली शोधन करवाने से हो जाता है। और दूसरा एक पेशेंट था जिसमें तो मैडम 0.01 था। हमने उसने भी सारी होप छोड़ दी थी, और मैंने भी यही बोला कि चलो ट्रायल एंड एरर करके स्टार्ट करते हैं। उसमें 6 महीने हमने वमन विरेचन करवाया, और एज यूजुअल में यज्ञ भी करवाती हूँ, तो वो भी करवाया, और वो आफ्टर 6 मंथ शी गेट प्रेग्नेंट, और अभी तो उसकी डिलीवरी भी हो गई। तो AMH
नाइस।
लेवल का हम ध्यान में रखते हैं, लेकिन बस सिर्फ उसी को पकड़ के नहीं चलते। और पेशेंट वो पकड़ के ही आते हैं कि मेरा तो ये AMH लेवल, क्योंकि उनको वो मॉडर्न डॉक्टर ने बता दिया होता है कि आपका ये लेवल कम है, इसलिए आपको कंसीव नहीं हो रहा है, तो आपको टेस्ट बेबी पे जाना है। लेकिन हम पर्टिकुलरली मैं उसको ऐसे प्रोग्नोसिस पे और जो कौन सी ट्रीटमेंट लेनी है वो उसके ऊपर उसका ध्यान रखती हूँ, बाकी ज्यादा उसको कंसिडर नहीं करती हूँ। और ये एक मेरा, हाँ, एक्सपीरियंस है AMH के लिए। पर फिर भी आज ये क्षय और आवरण, ये दोनों जो संप्राप्ति है, ये एक मुझे एक फंडा क्लियर हो गया कि हाँ इस तरह से ट्रीटमेंट चॉइस अब नेक्स्ट में रखना है। यस यस, ये है।
Nice. Thank you so much.
जी मैम।
Anybody else want to ask or add on? Dr. Sudha, ज्वाइन हो गई हैं आप, पर आवाज नहीं सुनाई दे रही। Ma'am, which are some good yogas for Avarana Janya, ma'am, in PCOS? Dr. Vidya?
Yes, ma'am.
Yeah. Divya has asked something. Yeah.
Ma'am, could you please repeat, ma'am?
Could you please mention some of the yogas which act when there is Avarana Janya pathology in PCOS?
Any formulation which is mentioned in Prameha Chikitsa can be adopted for Avarana. And Lashuna is one among the Shrestha drugs in reducing Avarana as far as Charaka is concerned.
Okay, are there any contraindications, ma'am, where we have to use Lashuna? Because this particular patient, what I was talking about, she has a fissure kind of problem. Occasionally, she has bleeding, but usually with Kamaduga and Avipattikar Churan and Gandhak Rasayan, when I give within 2-3 doses, she is okay. Maybe from the last 1 year, she's not having. Otherwise, repeatedly, she used to have. So she's very
I
careful
think
about her
the
diet.
fissure indicates Vata Prakopa, right? There might be, because the anal canal is become dried. That is why the fissure occurs. So we have to give Sneha. Either Sneha Vasti you can give, so that you can improve the AMH too. Because so you can improve the AMH too. Because the Apana Vata Vaigunya can be reduced by Sneha Vasti.
Sneha Basti
I
with
think
which Shaila, ma'am?
Any snigdha drugs like Dhanvantara, Mirupaka, or Kshirabala, or something like that, Pipalyadi Anuvasana. Some snehana should be given to the
Palyadi
anal canal.
Anuvasana. Yes, ma'am. Okay.
So Pipalya
And so,
Anuvasana is Artava Janaka too. So it
yes,
can
ma'am.
improve the AMH quality too.
And it is indicated in this also.
Yes,
I
yes,
should. Yes,
yes,
yes.
yes, yes.
Yes,
So
ma'am.
you
Can
can
Uttar Basti help, ma'am, in this case? Excuse me, ma'am.
Dr.
Ma'am is
Vidya,
asking, can Uttar Basti help?
can you listen, Vidya? उसके शायद नेटवर्क प्रॉब्लम चल रही शायद विद्या के यहाँ. Vidya, you are muted.
hello, ma'am.
Yeah.
Can you hear me, ma'am?
Can we give Uttar Basti, ma'am? In will it help in this case?
Yes, definitely Uttarabasti can be given, but only after the proper Shodhana and Rasayana.
Okay. Again, Uttar Basti with Tila Taila also would be good, no? Simple.
If Avarana is suspected, then you can give Uttarabasti with Taila Taila. Otherwise, what happens? It can irritate the uterine mucosa if directly Tila Taila is given. So either it should be processed. What is the main cause that you have to analyze and then select the drug?
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
Yeah, according to dosh, you have to select. If pitta is involved, you can use Grita Kalpana, and Vata and Kapha, you can prefer Taila Kalpana. That is also helpful in such type of cases.
कामनी मैम नमस्ते.
Namaste, madam.
हाँ मैम, ये जो आपने अभी बोला ना कि वी शुड टेक अ प्रॉपर हिस्ट्री, आइडेंटिफाई द दोषा एंड देन प्लान द शोधना. बिकॉज अभी रिसेंटली जो मेरा पेशेंट था विद लो एमएच, उसको पूरा प्रॉपर हिस्ट्री ली, उसका वेरिएशन प्लान किया, उसके बाद उसका आहार विहार उसी के प्रकृति के अनुसार चेंज किया, एंड देन शी गॉट प्रेग्नेंट. ऑल दो उसका थोड़ा सा प्रॉब्लम्स था कि वो ट्रैवल करने लगी उसके बाद ही, और शी गॉट अबॉर्टेड बट देन शी गॉट प्रेग्नेंट. तो दिस इज वेरी इंपॉर्टेंट कि विच शोधन वी शुड प्लान, एंड वी शुड ऑल्सो स्टडी द इटियोलॉजी कि क्या उसकी संप्राप्ति क्षयज है या आवरण जन्य संप्राप्ति है. तो जैसे मैडम ने बोला कि मैं लो एमएच तो देखती हूँ, पर मैं फिर शोधन करती हूँ, उसके बाद मैं नहीं देखती हूँ. तो शोधन का बहुत बड़ा रोल है. और जो हम ड्रग्स, जैसे अभी अभी मैडम ने बोला, सेलेक्ट करें, तो आपने भी बोला कि हम लोग उस पेशेंट की प्रकृति को स्टडी करके उसका दोष क्या है क्या नहीं, उसके हिसाब से फिर हम लोग अपनी जो मेडिसिन हैं, इवन जो घृत है स्नेहपान के लिए, वो हम लोग सेलेक्ट करें. बस यही मैं ऐड करना चाहती थी मैम. बहुत अच्छा सेशन था और बहुत अच्छे अच्छे सेशंस आप करवा भी रही हैं. थैंक यू मैम, थैंक यू सो मच.
Thank you, madam, for adding your experience in the session. Obesity is also having relation, I think, Dr. Vidya, with AMH. Not only infertility, but other also.
Hello, ma'am.
Hello.
Ma'am, I'm not hearing it clearly.
Actually, um, we have to continue this session. So I was asking that have you seen the relation of obesity with the level of AMH? That is a question from my side.
Yes. Obesity can affect the AMH, like anything, like obesity can lead to diabetes. Similarly, the quality of the ovarian reserve will also be affected if there is obesity. The proper metabolism is not happening. It can lead to thyroid dysfunction. It can lead to the recruitment of the follicles, and it can reduce AMH, or either it can increase AMH. Proper AMH will not be seen in obesity. Hello.
Yes. Nice. And what about that in your presentation you discussed about the AMH in male also,
Yes.
that it is being produced in Sertoli cells in the testis of
Yes.
males, and
AMH in
positive
males is
assay.
only having role.
Hmm.
AMH is having in males is having only role in sex differentiation during the embryological period. After that, it is not affected. Only in females, AMH is most important while doing the infertility treatment. In males, it is having function only in the embryological life.
Okay.
In recent studies, it has been told that it is also helping the AMH quality. If it is increased, it also helps in the secondary sexual characteristic development. So the Purushakara Bhava or Shukra Dhatu can be correlated with this AMH.
No, like when the patient is having PCOS and they are having also Purushakara Bhava, that facial hairs and like that. So
Yes, ma'am. So
any
Shukra Dhatu is more in PCOD, right? Testosterone is more in PCOD. That is why the facial hair, everything is occurring. But the thing which is needed, it is not functioning in PCOD. Proper ovulation is not happening in PCOD. So in such conditions, the Shukra Dhatu, due to the Avarana, the Shukra Dhatu is malfunctioning. So that Avarana should be removed first, ma'am.
Yes. That is clear. But that is we can say that theoretical discussion, that any relation with the Shukrakar Bhava uh, with the AMH, means it is increased when AMH increased in PCOS. We see the facial hair in cases of PCOS.
Yes, ma'am. Shukrakara Bhavas include these testosterone, everything. So, if it is present in females more than in males, then it causes the abnormality. If Shukrakara Bhava or Purushakara Bhava is present in Purusha, then it is okay. But if it is present in Stree, it can lead to the Vandhya told by the Charakacharya, ma'am.
And the
Ma'am,
patient who are having history of treatment of radiation, just one, sometimes the girls or females who are working in this X-ray unit. I had one patient, she was working in the X-ray unit, and influence upon the level of AMH, and they also decrease the level of.
Excuse me, ma'am. Ma'am, when you had told that the
Yeah.
AMH will be
Yeah.
increased till it grows up to 8 mm. So in case if we are seeing the checking the AMH on the second or third day of the cycle, won't it be less, ma'am, as
No,
compared
no, no,
to
no.
on the 10th
It is
day?
not. It is not having any relation with the day of the menstruation. In any
No,
day, the level will be the similar.
no, like in the second or the third day, the size of the follicle would be 2 to 4 mm. So if it is it something like when it grows to 2 to 4 mm, the secretion will be less, and when it goes to 8 mm, it will be more. And after 8 mm, it will be constant. Is it something like that?
AMH. Like that, ossiples is not having influence upon the level of AMH. Like that, pregnancy is also not having influence upon the level of AMH. Sometimes people are uh, having treatment of, we can say that modern treatment, that GnRH antagonist, agonist, they don't also have any influence upon the level of AMH. Right. Decrease by age, decrease by body mass index, and decrease by this chemotherapy and radiation. That is important. And increase by PCOS. This is the common things we see, and literature also say like that. That AMH level decrease with the age. And this is the marker of ovarian aging also. We can say that when it is continuously decreasing, we can say that patients are being aware that you may have, we can say, the premature ovarian failure, or you may enter into early menopause also. That is in clinical practice. Uh,
Yes, ma'am. Yes,
yeah,
ma'am.
yeah. And AMH level reflect the size of not a single follicle, but whole pool. We can say the primordial follicle pool. There is a pool that some follicle are trying to develop. That is known as primordial follicle pool. Well, lot many follicles are there. We can say that when a colony is trying to develop. So that pool is controlling of the level of AMH. Yeah, and that AMH suggesting what is the size of whole pool, not only one follicle.
Yes, ma'am, because there was a case, ma'am. She has endometriosis in her right ovary, and in the left ovary, it is multiple small follicle. Abhi this month's follicular studies, and she's 32 years. She's 32 years old, and her AMH was 0.57 in January when she saw. Abhi, then she took, sorry, in November. Then she took 3 months of homeopathic treatment, ma'am, for all this endometriosis. And after 3 months, when she checked, it went to 1.57 exactly after 3 months. But when she saw in November, it was on the second day of the cycle. And now, when she saw, it was on the 10th day.
But it is not having any relation of day of the cycle.
Day of the cycle, yes, ma'am.
It is not
And
having any. It is
yeah, but
like
her
we can say it is
condition,
just,
even with 1.57, is the same. One sided endometrioma, and the other side is multiple small follicles
it
on
can
the
be.
12th day. 12th
It
day
can
of
be.
the disease.
Yeah, it can be. It can
So
be. It is
this,
a
yeah,
general clinical.
improvement, but the improvement can be considered is because of the medicines only, ma'am. She
Yes,
has
yes,
taken
yes, yes.
0.5 to see the 1.57 in 3 months.
Yeah,
Yes, ma'am.
yes. That indicates the uh, follicles are multiple. So number of follicles might have increased. Developing follicles might have increased.
नहीं
Number of
ऐसा नहीं हो
follicles.
सकता है
Yeah.
मैम कि बहुत ज्यादा फॉलिकल्स हो गए इसलिए सब कोई सब फॉलिकल ने थोड़ा थोड़ा एएमएच सेक्रेट करके
Yes, yes,
इसलिए
yes,
ज्यादा हो
yes.
गया. So it could be that also, no, ma'am? Or should we consider it as an improvement from 0.5 to 1.5? क्योंकि उसने इस पेशेंट ने एक आईवीएफ किया था 2023 में और वो फेल हो गया. So doctors have told her to keep freeze her eggs because the AMH was 0.5. Now that she's happy it is 1.57, she's telling I need not freeze my eggs. तो अब ये पैथोलॉजी से हो गया है या इट इज द मतलब समथिंग गुड हैपनिंग कि उसकी एएमएच इंक्रीज हो गया.
Hello.
Hello, excuse me, ma'am.
Yeah. It was not audible for me for some time.
Yeah.
Yeah. So I think मुझे लगता है अभी कोई questions नहीं होंगे तो we can have conclusion of the session. पवन सर सुना ही नहीं रहे. 7-8 मिनट रहे हैं अभी उनके नेक्स्ट सेशन में.
हरिओम.
वो हो रही है.
हरिओम जी, हरिओम. हमारे साथ रामवीर सर आ गए हैं. आप चाहें तो एक बार उनकी ओपिनियन जरूर
वो
लें.
सेशन में नहीं थे, उन्होंने सुना नहीं ना.
कामिनी जी.
हाँ, वो सेशन में थे नहीं. बोलेंगे रामवीर सर 5 मिनट. कुछ आपका व्यू एक्सपीरियंस आपने सुना नहीं सेशन, अपना व्यू बता सकते हैं.
जी मैम, एक्चुअली मैं पेशेंट पर फंस गया.
जी
शाम
जी
के
जी
समय बैठता हूँ 6 से 9 बजे तक पेशेंट फंस जाता हूँ. टाइम लगता है. अभी खाने के लिए
जी
बैठा
जी
था.
जी
मैं सुन नहीं पाया, अभी जस्ट ज्वाइन किया. एएमएच के लिए मैम ने अच्छा बताया होगा, मगर जहाँ तक मेरा मानना है कि एएमएच जो है एंटी मुलेरिन हार्मोन, तो मैम ने बताया ये निश्चित सारी तरह से बताया होगा. एक्चुअली ये जो अभी जस्ट मैंने सुना मैम ने, जो पैथोलॉजिकली भी बढ़ जाता है. कई बार क्या है, ग्रेनुलोसा सेल्स की मात्रा ज़्यादा बढ़ती है. तो ग्रेनुलोसा सेल्स जो एंट्रम सेल्स, एंट्रम जो फॉलिकल होता है, उसके चारों तरफ के सराउंडिंग सेल्स होते हैं, वो इसको सीक्रेट करते हैं. और सीक्रेट करते हैं तो ग्रेनुलोसा सेल्स वही परिवर्तित हो जाता है ग्रेनुलोसा सेल्स में. और जैसे जैसे ग्रेनुलोसा सेल्स बढ़ते हैं वैसे वैसे एएमएच की मात्रा बढ़ती है. तो पीसीओडी होता है, उसके अंदर भी सेल्स अपने एएमएच बढ़ जाता है. तो पैथोलॉजिकली भी बढ़ सकता है कई बार. इसी तरह से अपने ग्रेनुलोसा सेल्स कार्सिनोमा होता है, तो उसके अंदर भी पैथोलॉजिकल बढ़ सकता है. हाँ, अगर फिजियोलॉजिकली बढ़ा रहे हैं, मेडिसिन के आधार पर बढ़ा रहे हैं, तो निश्चित ही उसका रिजल्ट मिलता है. अभी डिपेंड करता है कि प्रीमोर्डियल फॉलिकल्स कितने हैं, एंट्रम सेल्स कितने हैं. जितनी ज्यादा सेल्स होंगे उतना ज्यादा एएमएच होगा. और ये एडल्टहुड के बाद में बढ़ना शुरू हो जाता है महिलाओं के अंदर, पुरुषों के अंदर कम होना शुरू हो जाता है. तो ये बढ़ रहा है, कितना नॉर्मल है, इसके आधार पे वो रिजर्व रहता है कि इसके आधार पे एंट्रम सेल में कितने हैं, कितने फॉलिकल्स हैं, उसके आधार पे. अब इसको बढ़ाएं कैसे? मैं एक्चुअली क्या है, एएमएच जो है, मुझे लगता है जहाँ तक मुझे याद है, एएमएच जो है ग्लाइकोप्रोटीन है. हार्मोन अलग अलग टाइप के होते हैं, ग्लाइकोप्रोटीन है. और इससे जो ईस्ट्रोजन निकलता है जो ग्रेनुलोसा सेल से, वो है अपने स्टीरॉयड. तो स्टीरॉयड होने के परिणाम, और जो दूसरी चीज है, स्टीरॉयड इसी तरह से अपने अपने जो इसका एएमएच अगर कम होता है तो उसके लिए डीएचईए देते हैं, डीहाइड्रो एंडोस्टेरोन. ये कॉर्टिकोस्टेरॉइड है, स्टीरॉयड है. अब ये बनता है, स्टीरॉयड बनते हैं जैसे कोलेस्ट्रॉल से, और ये ग्लाइकोप्रोटीन है. तो जो ट्रीटमेंट हम लोग देते हैं, तो हमारे यहाँ जो आचार्य ने बताई है, मुझे लगता है बहुत ही जबरदस्त चीजें बताई है. मैं तो सोचता हूँ, उस दिन बात हो रही थी यष्टि मधु घृत की. यष्टि मधु घृत अपने बताया हुआ है कहाँ पर, अपने उसको बताया है शायद पांडु में, पांडु के अंदर बताया. उसमें त्रिकटु है, त्रिफला है, यष्टि मधु है और घृत है. तो घृत हो गया कोलेस्ट्रॉल के लिए, हो गया. तो इस तरह से जो हमारी मेडिसिन बनाई हुई है, इस तरह से काम करती होंगी. निश्चित ही एक बात बताई थी जैसे पहले भी हमने कामिनी जी ने कई बार बताया है, कई बार हम लोगों ने चर्चा की है, बीजम भगवती कारुकम, तो जो अपने बस्ती है और उसके बाद में मुख्यतः विरेचन है। तो विरेचन से मैंने देखा है कि विरेचन के बाद में एएमएच कई पेशेंट्स के अंदर बढ़ा हुआ है, और कैसे बढ़ता है इसके ऊपर तो मैं अपने डिटेल में बात कर सकते हैं, अपने अंदाज लगा सकते हैं कैसे बढ़ता है, ऐसा तो नहीं कह सकते, मगर विरेचन के बाद में भी एएमएच बढ़ता है, और कुछ प्रजा स्थापन मेडिसिन है उनके द्वारा बढ़ता है। और दूसरी चीज क्या है, एएमएच को डाउन करने वाले उन पेशेंट्स के अंदर देखा जाता है मोस्टली जो स्मोकिंग करती हैं या फिर माल न्यूट्रिशन की पेशेंट होती हैं, और स्ट्रेस सबसे बड़ा कारण है। तो मुझे लगता है पेशेंट को प्रसन्न रखें, स्ट्रेस न दें, न्यूट्रिटिव डाइट दें। अब ग्लाइकोप्रोटीन है तो ग्लाइकोप्रोटीन के अंदर ग्लाइकोजन भी, कार्बोहाइड्रेट भी चाहिए, प्रोटीन भी चाहिए, और स्टीरॉयड है तो उसके अंदर अपने स्टीरॉयड के अंदर अपने फैट भी चाहिए। तो ऐसी मेडिसिन जिसके अंदर अपने वो क्या नाम है, ग्लूकोज भी हो, कार्बोहाइड्रेट भी हो, प्रोटीन भी हो, और प्लस उसके अंदर फैट भी हो, तो इस तरह की घिरती ज्यादा काम करते जाए, चाहे वो फलवृत हो, चाहे वो शतावरी घृत हो, चाहे वो एस्टीमत घृत हो, तीनों का ही उन्होंने फलश्रुति बताई है, वहां पे प्रजा उत्पादन के लिए फलश्रुति बताई है। तो इनकी मेडिसिन का जो प्रयोग है, मुझे लगता है इसके अंदर अगर विरेचन देने के बाद में स्टेन करें, स्टेन करके बाद विरेचन दें तो बीजम भवती कार्मुकम, तो हो सकता है ग्रेनुसा सेल्स ज्यादा बढ़ाएंगे नहीं, एंट्रम में जितने सेल्स पड़े हुए हैं वही होंगे, मगर उनकी जो बाहर की अपने फॉलिकल के बाहर के सेल्स हैं उनको हो सकता है उनको फंक्शन को मोटिवेट करते हो जिससे एमएच बढ़ता हो, ये संभावना है। मगर जो संख्या है उसमें संख्या को तो नहीं बढ़ाना मुश्किल है, तो जो डैमेज होगी, जैसे अपने 25 साल के बाद में इसमें डिग्रेडेशन होना शुरू हो जाता है, तो फॉलिकल्स जो है उनका धीरे धीरे करके 400 फॉलिकल पूरे लाइफ स्पान में अपने परिपक्व होते हैं और लाखों होते हैं। तो जैसे जैसे कुछ कम होते जाएंगे तो वो तो संख्या बढ़ेगी नहीं, मगर उनके अंदर जो सेल्स है उनको शायद स्टिमुलेट करते हो और उसको मोटिवेट करते, स्टिमुलेट यानी उसको क्या नाम है, अपने फंक्शन बढ़ाते हो जिससे एमएससी होता हो एंट्रम के सेल के चारों तरफ की सेल्स को, तो हो सकता है मेडिसिन इस तरह से काम करती है। तो निश्चित ही विरेचन, उत्तर बस्ती और हमारी घृत जो बताए प्रजा स्थापन के अंदर वो, और घृत स्थापन के अंदर साथ में आत्मा अग्नियम कहा गया है, तो प्रोटीन का जो कार्य है, और जैसा जानते हैं अपने डीएचईए है, ये डीएचईए क्या है, अपने स्टीरॉयड है, तो स्टीरॉयड भी उष्णता से बढ़ते हैं, उनका मेडिसिन अगर पंचकूल वगैरह को ओवुलेशन के लिए पंचकूल वगैरह देते हैं तो उसका रिजल्ट मिलता है। तो मुझे लगता है कि आचार्यों ने जो मेडिसिन की अगर उसको अपने क्लासीफाइड करें किसको कहाँ देना है, और साथ में अपने न्यूट्रिशन सही दें, विटामिन ए दें। हाँ, एक चीज और, विटामिन डी की कमी से भी एएमएच कम होता है, उन महिलाओं के अंदर ज्यादा देखा गया है विटामिन डी जिनके अंदर कम है, तो विटामिन डी जिनके अंदर कम है तो उनको अगर विटामिन डी के लिए धूप के अंदर सेवन करेंगे, इसलिए मजदूर काम करते हैं, धूप में काम करते हैं, किसान काम करते हैं, उनके अंदर इन्फर्टिलिटी बहुत कम होती है, और सैनिटरी लाइफ जी रहे हैं जिनके अंदर धूप नहीं प्राप्त हो रही है उनके अंदर एएमएच कम मिल रहा है, ऐसा देखा गया है। तो मुझे लगता है धूप भी जरूरी है, विटामिन ए भी जरूरी है, विटामिन ई भी जरूरी है, तो पूरा न्यूट्रिशन साथ में दे और प्रोटीन सही तरह से दे तो निश्चित है इसमें रिजल्ट मिलेगा। मैम ने जो बताया मैं सुन नहीं पाया, उसको मैंने मिस किया, उसके लिए सॉरी, और आप लोगों ने मुझे बोलने के लिए समय दिया उसके लिए बहुत बहुत धन्यवाद। मैं थोड़ा सा पेशेंट में शाम के समय पेशेंट देखता हूँ, पेशेंट फंस जाता हूँ तो फिर मैं ज्वाइन कर पाता, अदरवाइज मैं कामिनी जी के सेशन को ज्वाइन करने की कोशिश ही करता हूँ, मुझे सीखने मिलता है। थैंक यू वेरी मच।
थैंक यू वेरी मच रामवीर सर, थैंक यू वेरी मच। आदरणीय कामिनी जी से मैं, कामिनी जी का कनेक्शन कहाँ गया? अगली वेबिनार हमारी सिजोफ्रेनिया पर है, तो कृपया जुड़े रहें।